Hello, everyone, and welcome to our module on autonomic drugs, acetylcholine. Here's our map of the autonomic nervous system, and in this video, what we're going to do is focus on drugs that either activate acetylcholine receptors or block acetylcholine receptors. So let's start by talking about the major roles that acetylcholine plays in the body. So first of all, acetylcholine is the major neurotransmitter for the parasympathetic system. Acetylcholine is also important for your sweat glands. That's part of the sympathetic system, but nevertheless, when you activate or block acetylcholine receptors, you will have an impact on the sweat glands of the body. And then finally, acetylcholine is very important for skeletal muscle cells for our voluntary motor actions. So when you activate or block the effects of acetylcholine, you can see effects on skeletal muscle as well. So these are really the three main things you want to think about in terms of clinical effects of acetylcholine: the parasympathetic nervous system, the sweat glands, and skeletal muscle. Let's start by talking about nicotinic acetylcholine receptors. These are found in a number of places in the body. In particular, you can find them in the ganglia for the parasympathetic nervous system and the sympathetic nervous system as shown on our map. But in terms of clinical effects of activating or blocking nicotinic receptors, the skeletal muscle is what usually dominates. So skeletal muscles are innervated by nicotinic receptors and acetylcholine as a neurotransmitter. So anytime you activate nicotinic receptors, what you see clinically are effects on muscles like spasms or fasciculations. And anytime you block nicotinic receptors, the dominant effect is paralysis because you block the ability of the body to use skeletal muscles and to conduct motor function. So in this video, I'm going to talk about some drugs that have effects on nicotinic receptors, but drugs that predominantly block nicotinic receptors are used as part of anesthesia to paralyze patients having surgery, and I talk about those in a separate video in the anesthesia section on neuromuscular blockers. Let's review a little vocabulary. Anything that is said to be cholinergic is related to acetylcholine, so therefore cholinergic receptors are receptors that bind acetylcholine. The word toxidrome means signs or symptoms of poisoning or an overdose, and so there are so-called cholinergic and anticholinergic toxidromes that you need to know for step one. These are classic toxidromes that occur when you either overactivate the cholinergic receptors or you block all the cholinergic receptors. And if you understand these toxidromes, then it's very easy to understand cholinergic and anticholinergic drugs, because all of those drugs are designed to purposely cause some part of the cholinergic or anticholinergic toxidrome in order to improve a patient's condition or symptoms. So let's start by talking about a cholinergic toxidrome. This is the set of signs and symptoms that occur when you activate all the cholinergic receptors in the body. And the classic cause of a cholinergic toxidrome is organophosphates. Organophosphates are found in pesticides. They have a structure like what's shown on the screen here. They have a phosphorus double bonded to an oxygen, lots of other oxygens and carbon groups, those are the R's. And what organophosphates do when humans are exposed to them in high quantities is they inhibit acetylcholinesterase. This is going to amplify the effects of acetylcholine throughout the body. By way of review, when acetylcholine is released into a synapse, it can then go on to bind to a muscarinic or nicotinic receptor. What acetylcholinesterase does is break it down into choline or acetate. So if you are exposed to organophosphates and you inhibit acetylcholinesterase, the levels of acetylcholine are going to rise in all the synapses in the body, and this is going to produce a cholinergic toxidrome. So a cholinergic toxidrome is very easy to understand if you understand what the parasympathetic nervous system does, which I talk about in the video on the autonomic nervous system. Basically, you get all the actions of acetylcholine in the parasympathetic system plus sweating, because that's part of the sympathetic system, but it's mediated by acetylcholine. So people exposed to organophosphates who have a cholinergic toxidrome will have increased GI motility, and that means they will develop symptoms like nausea and vomiting, cramps, and especially diarrhea. Diarrhea is a key feature of a cholinergic toxidrome. All of their secretory glands will be activated, like sweat glands and salivary glands, so they will be sweating, salivating, their eyes will be teary, that's lacrimation. The bladder is activated by the parasympathetic system when you want to urinate, so the detrusor, which is made up of smooth muscle in the bladder, will contract, and that means that people exposed to cholinergic toxicity will have incontinence from urination. So you can just remember this as diarrhea, drooling, and incontinence. These are three obviously unusual features that, when they occur together, should immediately bring to mind a cholinergic toxidrome. Other features of a cholinergic toxidrome are shown here. In the heart, you will have decreased contractility and decreased heart rate. So someone who comes in with nausea, vomiting, and diarrhea and has a slow heart rate, that's very unusual, and that should remind you of a cholinergic toxidrome. In the lungs, activation of acetylcholine receptors will lead to bronchoconstriction, so this will lead to wheezing, dyspnea. Patients who have a history of asthma or COPD may experience a flare when they are exposed to organophosphates. So bradycardia and wheezing are the two symptoms that, if you see together, should bring to mind a cholinergic toxidrome. And then some final features of the toxidrome are shown here. In the eyes, the pupils will be pinpoint. That's because the pupils are constricted from excess activation of the parasympathetic system. Nicotinic receptors at muscles will also get activated, so patients can have muscle twitching. And then finally, there are acetylcholine receptors within the central nervous system, so those will also be activated. And this can lead to symptoms like confusion, lethargy, or even sometimes seizures, all from overactivity of acetylcholine within the brain. The mnemonic that's often used to remember these signs and symptoms is dumbbells. The D is for defecation, the U is for urination, the M is for meiosis, which means small pupils, the B is for bronchospasm or bradycardia, the E is for emesis, the L is for lacrimation, and the S is for salivation. So here's a description of what organophosphate poisoning will look like in a board question. A 44-year-old farmer presents to the ER with difficulty breathing. There is audible wheezing. He also reports diarrhea and unintentional loss of urine. He appears confused. On exam, he has pinpoint pupils. He is sweaty, drooling, and his eyes are watery. His pulse is 30. This is a classic description of an organophosphate poisoning and a cholinergic toxidrome. It will come up in step 1, step 2, and step 3. It also comes up in medicine boards and emergency medicine boards. Learn it and get it right. It's easy points on the boards if you know how to recognize it. There are two treatments for a cholinergic toxidrome. The first one is atropine, which we'll talk about later in this video. Atropine is a muscarinic receptor antagonist, so it will block the muscarinic receptors and relieve many of the symptoms caused by acetylcholine activation there. Second treatment is pralidoxime. This is a drug that regenerates acetylcholinesterase. It's a cholinergic poisoning antidote. What it does is it binds to acetylcholinesterase and displaces the organophosphates and allows the enzyme to begin working again. So now that we understand what a full-blown cholinergic toxidrome looks like, we can talk about drugs which are acetylcholine receptor agonists. These drugs are designed to cause some component of a cholinergic toxidrome in order to benefit the patient. Before we can talk about these four drugs, I need to briefly review a little bit of organic chemistry. Amines are structures that have a nitrogen attached to an R group, meaning a group containing carbons. A primary amine is attached to one R group, a secondary amine to two R groups, a tertiary amine to three R groups. So any structure that is a tertiary amine has a nitrogen with 3 carbon bonds, and structures that are tertiary amines can penetrate the blood-brain barrier, and this will be important when we talk about these drugs that are acetylcholine receptor agonists. Quaternary amines are nitrogens that have 4 carbon bonds, and these cannot cross the blood-brain barrier, and this will also be important. So for example, if you look at the bottom of the screen, this is the structure of pilocarpine. It has nitrogens with only 3 bonds to carbons within its structure, so it's a tertiary amine. Bethanechol, shown at the bottom right, has a nitrogen with 4 bonds to carbons, therefore it is a quaternary amine. So now that we understand that, let's talk about drugs that are acetylcholine receptor agonists. The first drug is bethanechol, and it has a similar structure to acetylcholine. If you look at the bottom of the screen, it looks just like acetylcholine except for modifications at this end of the molecule. This NH2 group it has right here, you'll find in several of the drugs we're going to talk about, and that's important because that gives the molecule strong resistance to the enzyme acetylcholinesterase, and this allows it to have a longer duration of action than if that NH2 group were not present. In addition, bethanechol has what's known as a beta-methyl group. That's this methyl group right here as part of the molecule, and the presence of that methyl group gives bethanechol reduced activity at nicotinic receptors so that it won't affect skeletal muscles very much. Therefore, this drug has muscarinic activity only. And times that this is sometimes used is in patients who have ileus, which is where the gut is not moving. This often happens after surgery. Also among patients with urinary retention, this can get the parasympathetic system going again and help patients to be able to urinate. Next, let's talk about carbachol. Just like bethanechol, carbachol is a drug whose molecular structure mimics acetylcholine. The only difference is the addition of this NH2 group. And as I told you on the last slide, that NH2 group provides strong resistance to breakdown by acetylcholinesterase, and this increases the duration of action of the drug. Carbachol does not have a beta-methyl group like bethanechol, therefore it has activity at nicotinic and muscarinic receptors. And carbachol has a number of small niche uses. One of them is it's administered topically to constrict the pupil. This can be done in the setting of glaucoma to lower the intraocular pressure. If you want to keep glaucoma simple for yourself, just remember that anything that activates the sympathetic nervous system tends to make it worse, and anything that activates the parasympathetic system tends to make it better. So carbachol, being an agonist to muscarinic receptors of the parasympathetic system, can be used to improve glaucoma. Next, let's talk about methacholine. Methacholine looks just like acetylcholine, but it has a methyl group added. That's why it's called methacholine. And the addition of the methyl group provides some acetylcholinesterase resistance, but not as much as the other drugs that have an NH2 group. However, that methyl group is a beta methyl group, so just like with bethanechol, this provides reduced activity at nicotinic receptors. And the main use of methacholine is in diagnosis of asthma. It is inhaled in low dosages. Patients who react to those low dosages with bronchoconstriction are likely to have asthma. And the last drug we'll talk about that is an acetylcholine receptor agonist is pilocarpine, and it's totally different from all the others in this class. The other drugs we've talked about up to now, like bethanechol and carbachol and methacholine, they all have chemical structures designed to mimic acetylcholine. Pilocarpine has the structure shown at the bottom right side of the screen, and it doesn't look anything like acetylcholine. Instead, pilocarpine has elements designed to mimic nicotine or muscarine and activate the receptors by mimicking those substances. Therefore, it can stimulate both nicotinic and muscarinic receptors. It's also a tertiary amine. If you look at its structure, the two nitrogens have 3 bonds to carbon, so it's a tertiary amine. That means it can cross the blood-brain barrier, and one of its potential side effects when it's given systemically is that it may cause seizures. It's used in the treatment of a couple of conditions. The first one is glaucoma, which I talk about in a separate module. But in treating glaucoma, if you can increase activity of the parasympathetic system and decrease activity of the sympathetic, you will lower the intraocular pressure. Sjogren's syndrome I talk about in the immunology section, but it is a condition where patients cannot produce saliva, so they have dry mouth, and pilocarpine can be used to increase saliva production. And then in cystic fibrosis, which I talk about in the pulmonary videos, the sweat test is one of the ways you can diagnose the condition. So pilocarpine is administered to the skin, and the idea here is to activate sweat glands by activating acetylcholine receptors and cause sweat to be produced. So one way to increase activity at acetylcholine receptors is through drugs that are agonists to the receptors. Another way is to increase activity at the receptor indirectly by inhibiting the enzyme acetylcholinesterase. So drugs that are so-called cholinesterase inhibitors increase acetylcholine activity indirectly by blocking the breakdown of acetylcholine in synapses, and therefore they can activate both muscarinic and nicotinic receptors. And all of these drugs shown on the screen here work this way. We'll go through them one at a time in the next few slides. So just by way of quick review, if you inhibit acetylcholinesterase, you boost the levels of acetylcholine in synapses, and that can increase activity at both muscarinic and nicotinic receptors. This is the same thing that happens in patients who have organophosphate poisoning. Shown on this table are 4 drugs that work by inhibiting acetylcholinesterase. The first one is neostigmine. It is a quaternary amine. Note that it has a nitrogen attached to 4 carbons, therefore it cannot cross the blood-brain barrier. It has a very short half-life, and it's sometimes used in patients who have ileus, meaning they don't have movement of their gut after surgery. It's also often used in myasthenia. Many of these drugs shown on this slide are used in myasthenia gravis, which is a neuromuscular disorder that I talk about in videos in the musculoskeletal section. But patients with that disorder have decreased activity of acetylcholine at their skeletal muscle synapses. So drugs in this class can be used to boost acetylcholine levels and improve muscle function. Pyridostigmine is another drug in this class. It is also a quaternary amine and cannot cross the blood-brain barrier. It has a relatively short half-life, and it can be used in myasthenia. Physostigmine is the one drug shown on this slide that is a tertiary amine. Its nitrogen groups only have 2 or 3 carbon bonds. None of them have 4 carbon bonds. That means it can cross the blood-brain barrier. For this reason, it is the drug of choice in anticholinergic toxicity, which we'll talk about in a minute in this video. But if someone has anticholinergic toxicity, they have poisoning of their cholinergic receptors, not only peripherally, but also in the brain. So you want to use a drug like physostigmine that is a tertiary amine. It can cross the blood-brain barrier and relieve the central nervous system effects like delirium and confusion. And then the last drug in this class is really historical. It's not used anymore. It's called edrophonium. It is a quaternary amine with a very, very short half-life, and years ago it was administered at the bedside to see if a patient with neuromuscular weakness would have improvement after they received the drug. If they did show improvement, that meant they had a diagnosis of myasthenia gravis. Nowadays, we have antibody tests for myasthenia, so edrophonium is not used anymore at the bedside. And next, I'll talk about donepezil, which is also an acetylcholinesterase inhibitor, but it's a little different from the four others on the last slide. It's a tertiary amine. Its structure is shown here, so it can cross the blood-brain barrier. And the real use of this is in Alzheimer's disease. That's because it's relatively selective for the synapses in the brain, in the central nervous system. It has less activity peripherally, and therefore it's been used to increase acetylcholine activity in the brain. There is what's known as the cholinergic hypothesis, which hypothesizes that one of the causes of Alzheimer's is low activity of acetylcholine in the brain, so this drug can boost the activity. And donepezil was the first drug like this on the market. Two others have since come on the market. One's called galantamine, the other's called rivastigmine, but they're all acetylcholinesterase inhibitors that are selective for central nervous system synapses. Let me briefly mention COPD and peptic ulcers. Any cholinergic medication can worsen these two conditions, either drugs that are acetylcholine receptor agonists or drugs that are acetylcholinesterase inhibitors. The reason for this is because drugs like this can cause bronchoconstriction, which can cause COPD to flare. They also can increase gastric acid production, and that leads to ulcers. In the GI section, I talk about the control of gastric acid production in the stomach, but anytime you activate muscarinic receptors, you get more gastric acid production. Remember that the parasympathetic system is the rest or digest system, so anytime you activate parasympathetic receptors, which are cholinergic, you are going to get more gastric acid production in the stomach. Okay, so everything up to this point we've been talking about has to do with activating cholinergic receptors. Now we're going to go 180 degrees in the opposite direction and talk about what happens when you block cholinergic receptors. And just like we did with activating cholinergic receptors, we'll talk about blocking those receptors by discussing an anticholinergic toxidrome. Because if you understand this toxidrome, then it's very easy to understand how drugs that block cholinergic receptors work. So patients can present to the emergency room with an anticholinergic toxidrome if they've been exposed to excess amounts of drugs that block cholinergic receptors or to some plants. Drugs that can cause an anticholinergic toxidrome include antihistamines like diphenhydramine, which is Benadryl if people take too much of this. Although these drugs block histamine receptors, they also block acetylcholine receptors. Tricyclic antidepressants have acetylcholine blocking effects. Drugs like amitriptyline, they can cause an acetylcholinergic toxidrome if a patient overdoses. And then atropine, which we'll talk about later, is a classic cholinergic receptor blocker. And so if a patient has received this, they can develop signs and symptoms of a cholinergic toxidrome. And then in terms of plants, the classic cause of an anticholinergic toxidrome is Jimson weed. This is a plant called Datura stramonium, and patients who are exposed to this, usually it's a gardener, can develop the signs and symptoms of an anticholinergic toxidrome. This is a picture of a Jimson weed on the screen here, and what you need to know about this weed when it grows in gardens is that it contains substances called anticholinergic alkaloids. This is what you'll read in your textbooks. An alkaloid is a nitrogenous plant compound, and atropine and scopolamine, which is another anticholinergic drug, are both nitrogenous plant compounds. This is the structure of atropine and scopolamine on the screen here. And if you know that atropine is the classic anti-muscarinic receptor drug, then it's very easy to remember that Jimson weed contains atropine, and then you will know what happens when you are exposed to Jimson weed. So now let's run through the signs and symptoms of an anticholinergic toxidrome. Once again, if you know how the parasympathetic system works, it's very easy to understand this toxidrome, because basically what you have is blockade of all of the effects of the parasympathetic nervous system. So first of all, patients with this toxidrome have dry skin. That's because they cannot sweat. They will also be hot. They will have high temperature, and that's because you need sweating to dissipate heat. So anyone who can't sweat is going to very easily get overheated. And when these patients get overheated, they will develop flushing. That's because their skin will vasodilate in response to hypothermia, trying to get rid of that heat by bringing blood to the surface of the body, although it's hard to get rid of the heat because you really need sweat to get rid of heat. So anyone who can't sweat is going to have the three features shown on this slide: dry skin, hyperthermia, and flushing. These are classic features of an anticholinergic toxidrome. Other features of an anticholinergic toxidrome are shown on this slide. Patients will be very dry. They will have dry mouth and eyes in addition to the dry skin. That's because they can't lacrimate or salivate. Their pupils will be dilated, like this one shown on the screen here. That's called mydriasis, and that's because you are blocking the effects of the parasympathetic system and allowing the sympathetic system to go unblocked, and that leads to dilation of the pupils. And in the video on glaucoma, I talk about how dilated pupils can trigger acute angle closure glaucoma, and that's one thing that can happen to susceptible patients if they develop an anticholinergic toxidrome. In addition, you cannot accommodate the lens that requires functioning of the parasympathetic nervous system, and this leads to blurry vision. And then finally, when you block central nervous system acetylcholine receptors, this can lead to delirium. So the classic mnemonic for an anticholinergic toxidrome is shown on this slide. You should understand this now after what we've been talking about. Patients who have this toxidrome are red as a beet from flushing. They're dry as a bone because they can't sweat or make tears or make saliva. They're blind as a bat because they have blurry vision from loss of accommodation of the lens. They're mad as a hatter, that's the delirium, and they are hot as a hare, that's because they cannot sweat. The treatment for an anticholinergic toxidrome is a drug we've already talked about, physostigmine. As I mentioned before, it's an acetylcholinesterase inhibitor. It will block acetylcholinesterase and boost levels of acetylcholine in synapses. It's a tertiary amine, so it crosses the blood-brain barrier and can treat the delirium component of the toxidrome, and it's going to generally boost acetylcholine levels throughout the body. Okay, so now that we understand what a full-blown anticholinergic toxidrome looks like, let's talk about some drugs that have anticholinergic properties. So as I mentioned earlier in this video, atropine is the classic drug that is a muscarinic receptor antagonist. It's used in many places, but one of the ones that you're likely to see in your clinical rotations is that it's used for bradycardia in patients having a cardiac arrest. So when patients have a cardiac arrest, you go through what's known as the ACLS algorithm, which involves things like chest compressions and shocks, but it recommends several drugs to be administered, and one of them is atropine when the heart rate is slow. And that's because what atropine will do is speed up the heart rate. So this is an ECG strip showing marked bradycardia. If you administer atropine, the heart rate will pick up. And just like we mentioned before, an overdose or an excessive dose of atropine can cause all the features of an anticholinergic toxidrome. Scopolamine is another muscarinic receptor blocker. It's a treatment for motion sickness. So motion sickness is complex, but it's believed to be related to overactivity of acetylcholine and histamine in the brain. There's also some role played by dopamine. These overactive synapses in the brain lead to nausea and vomiting. So scopolamine can be used as a treatment for motion sickness because it blocks M1 receptors. What you do is you wear a small patch on your skin, it's absorbed into the body, it blocks the M1 receptors, and if you ever go on a cruise ship, you'll see lots and lots of people wearing these scopolamine patches. Other drugs that can be used for motion sickness are antihistamines because histamine is important as well. So you may know that meclizine is antivert and dimenhydramate is dramamine. These are also used for motion sickness. And after everything we've been through in this video, it should be very easy for you to understand the side effects of scopolamine. Those include dry mouth, urinary retention, and constipation, all classic anticholinergic side effects. If you've ever been to the eye doctor, you've probably had your pupils dilated. That's called mydriasis. This is often done for examination of the retina and other structures in the back of the eye. And you should be aware that anticholinergics are commonly used for this purpose. One of the most commonly used drugs is tropicamide, which is administered as eye drops. Other drugs can also be used. These include homatropine, cyclopentolate. Atropine itself can even be used, and so can scopolamine. All of these are simply blocking muscarinic receptors in the eye and causing the pupil to dilate. Anticholinergics are sometimes used in the treatment of Parkinson's disease. Parkinson's disease I discuss in another video, but it's caused by depletion of dopamine activity in the central nervous system. When dopamine activity is depleted, there's a relative excess of acetylcholine activity, and therefore using drugs that are anticholinergics sometimes restores the dopamine to acetylcholine balance. And the two drugs that are often used for Parkinson's are benztropine and trihexylphenadil, which are both shown here on this slide. Overactive bladder is a potential cause of urinary incontinence, and anticholinergic drugs can be used because they inhibit the detrusor muscle function. In the video on the autonomic nervous system, I talk about how parasympathetic nerves are what stimulate the detrusor muscle to contract so that you can urinate, and overactive bladder is thought to result from spasms or overactivity of the detrusor muscle, so anticholinergic drugs can be used to block this from happening. Drugs that are used for this purpose include oxybutynin, solifenacin, and tolterodine. All three are anticholinergics. A couple of other drugs that are anticholinergics are listed on this slide. In COPD, ipratropium and tiotropium are sometimes used. These drugs block the effects of the parasympathetic nervous system and acetylcholine, which leads to bronchoconstriction. So by blocking those effects, you can get bronchodilation and improve symptoms of COPD. And then glycopyrrolate is a drug that's sometimes given preoperatively. When patients are intubated in the operating room, they can develop a significant amount of airway secretions, which can plug up their lungs. So by giving glycopyrrolate, you block the ability of secretions to form because you're blocking the parasympathetic system, and that is sometimes beneficial. I'll finish with this slide and summarize the most important points to remember about what happens when you have a toxidrome that involves some form of poisoning of the acetylcholinesterase synapse. If you have a cholinergic toxidrome, the classic cause of which is organophosphates, you will see nicotinic and muscarinic receptor activation. This will cause patients to be wet, they will drool, have tears, and be sweaty. They will be slow, they'll have bradycardia, and their pupils will be small and pinpoint. So wet, slow, and small is another way you can remember the cholinergic toxidrome. Patients with an anticholinergic toxidrome, the classic cause of which is Jimson weed, will have muscarinic blockade throughout the body. They will be dry with a dry mouth and no sweat, and they will have dilated pupils. That's mydriasis. So dry and dilated is a way you can remember the anticholinergic toxidrome. And that concludes our video on autonomic drugs acetylcholine.